of work that you shared with us, and I think it's exactly the type of work we need to keep replicating to figure out where the problems are and then hopefully where the solutions are too. I think just being mindful of time, I do want to give Dr. Saleh the chance to get through his talk, and then hopefully if people are still around, we can have questions for everybody at the end here as well. That's okay. Perfect. All right. So next up, and finally, Dr. MIKAIL Saleh. He is the current neurosurgeon at Maputo Central Hospital with a subspecialty focus on skull base and spine surgery. He completed his skull base fellowship in Brazil, actually, under Professor Luis Borba, and also has a PhD in neuroscience. And he's currently the president of the Association of Neurosurgeons of the Portuguese-speaking African country. So really excited to learn from him as well about the challenges of neurosurgery in Mozambique.
Okay, thank you. First, I would like to thank for this invitation and to be a part of this webinar with great names of the school-based surgery, the world like Professor Revedel and Lucas. So I'll start share my screen. Are you see?
Yes.
Can you see my presentation?
Yes.
Okay. Now you can see.
We see the slides not in presenter view, but we still can see the slides if you want to click through them.
Okay. You see the slides, okay?
Yes.
So I will talk about my experience in the challenge that I face daily here in Mozambique. My name is MIKAIL SALLE, I'm a neurosurgeon for Mozambique, and I made my medical residence in Cuba during 5 years. Then I spent 2 years with Professor Borba doing my clinical fellowship in school-based surgery. So I come to my country last year, and I'm from here, Mozambique. Mozambique is the Southeast
All right,
African
Dr. Saleh.
country.
I think
Yes.
the slides, we still only see the non-presenter view. So if you perhaps try slideshow, view show, we're still just on the title
Okay,
slide
I
here.
will stop and okay.
Sorry about that.
Are you see now?
Not yet. We see you, not the presentation.
Oh, I will try this. Now?
Uh, yes, we see the version we still see your slides on the left-hand side. So if you want to click through them on the left-hand side of the screen, then we should be able to see each successive slide.
I will try. Let me do this again. And now?
Again,
You
looks
can click on the slideshow button.
But you see the slide.
No,
yes.
it's just fine.
We don't see it full screen as a presentation. We only see the slide as if you were creating the presentation. So if you have it on that view and click through the slides on the left-hand side, we can still see them, just like Dr. Lima did again.
Okay. Let me. And now? Still
No, sir, not yet.
not yet. Oh, I have a problem here.
Yes, if you
Okay, I
just
will try.
yes, go ahead. If you have the slides as you had them initially, then instead of using, the slideshow
Okay.
mode, you can just click through them and then we can at least see.
Okay. Okay, I will try. Let me. And now you can see.
Yes, we can see. And then on the left-hand side, we see your next slide. So
Okay.
you just click there. It should be okay.
Okay.
Yeah, you can keep it this way. Just keep moving the slide exactly like you just did.
Okay. Okay.
Click in the one that you want, and it should be fine.
Okay. Okay. Thank you. So Mozambique is a southeast country in Africa. We are border with South Africa, Zimbabwe, Tanzania, and Malawi countries. Our official language is Portuguese, and we are 34 million people. According with HDI, we are low MIC country. So the neurosurgery in Mozambique is the same with many countries here in Africa. We are only 16 neurosurgeons for 34 million people. So in Mozambique, we had 4 neurosurgical service and only one school-based neurosurgeon. We have 2 centers that we have a program of neurosurgery and 2 residents of neurosurgery. The neurosurgery program in Mozambique during 5 years. So this is my hospital, Maputo Central Hospital. We had 15,000 beds and 15 operating rooms. Our neurosurgery service had 7 neurosurgeons, 8 residents, and 4 beds. So, let me pass. Okay. The main cases of the admissions in our hospital, as many countries here in Africa, is the traumatic brain injuries. Then we have spine injuries, hydrocephalus, and tumors. About the school-based lesions, most of these lesions are basically fractures. Then we have meningiomas, pituitary tumors, schwannomas, and others. But this is our reality for school-based surgery. In Mozambique, we don't have microscopic, we don't have endoscopic, and this is our reality. We still have basic instruments, and with these basic instruments, we try to do our best. Unfortunately, in Africa, we have the same, in the same cases, we have the same reality, but some countries have a particularly difficult. In Mozambique, still have these difficulties. So this is our one of the most cases that we face our in our works. For example, this is meningiomas. We have schwannomas, and we still have difficulties. Our difficulties, as Dr. Clay said here, with the papers, as the same. We have a lack of adequate instruments to school-based surgery. There is not enough investment in neurosurgery in our country. So as I say, my presentation will be short because in school-based surgery, unfortunately, we have many difficulties to have instruments to perform our surgeries. You can see my slide.
Yes, we can. I appreciate
Okay.
it. Looks like you're on the, coming towards the end there. Is that
Please
right?
look for this slide. This is our instruments, our device. to perform our surgery. Okay. So as I said, my presentation will be a short, and thank you for
Thank
this
you so much.
opportunity. Thank you, Professor Provedelho.
Well, thank you. I think that we've really seen a full spectrum today, even in just these three examples of the different challenges that people face in
Yes,
different.
yes. My focus will not be say about tips and tricks because it's already spoken by my dear colleagues here.
Yes,
I
much
think
appreciated.
yeah, you did a great job closing the main aspect of the goal of this discussion, which is the difficulties, the lack of equipment, something that Claire mentioned, how much she worked in the beginning there, like to be able to build not only for courses, but also to be able to do the cases, get a microscope here, a tower there. I remember, Mikhail, when we talked early in March that I had the pleasure to meet you personally. You mentioned how difficult it is. You have to use towers with urology. They have priority. Priority is non-neurosurgery in these places. That was very impressive and shows the reality, how difficult it is. And I think the whole world, we're trying to help, but there's limitation. You guys have a population that is millions and millions of people there that need help. And well, we do what we can do. So like I mentioned, Claire will be happy to help you with the next adventure for courses there. We can be in touch, and maybe we can do something with Mikhail together, and Lucas and Said, and a lot of people listening here. Anyone has any idea to how to improve and make things better for the developing countries, I think we're all happy to help. Said, what do you think?
I think that's beautifully summarized. The themes that really jump out to me are indeed the training and the equipment. And I think one of those, at least from a training perspective, is something that we can try and bridge the gap even overseas. I think this idea of doing tele-mentoring and long-distance mentoring, like Dr. Lima mentioned, is one area that we really have the opportunity as early as now to do without requiring millions of dollars. So I'm really thinking hard about how we can do that at a high level and at scale. So I'm really excited about that. I see Dr. Abdul-Bar unmuted himself as well.
Yeah, thank you so much for the speakers. I think this was a wonderful tour of, the challenges as well as, the solutions. And I think that, as Dr. Prevedella said, we'll be working hard to, find those solutions so that it's not just makeshift, but also taking us to the next level. And I think that, some of the tricks that you have mentioned, they can actually be transferred from the LMICs to the HICs and back and forth. And I think together we'll make this a reality. So thank you all to the speakers and to all the people that attended it. I think we can have a few minutes for questions, Syed.
Yes, absolutely. If anybody in the audience has questions, by all means, feel free to fire away in the chat. But otherwise, I can start us off with at least one. For Dr. Karakezi, I think one of the things that shot out to me was you did these amazing, beautiful surgeries, really intense, and then a patient would die postoperatively from hyponatremia, for example. So how do you bridge that gap of being able to provide your niche area of expertise, but really still being reliant on good endocrinology care or even good ICU care, or all these other elements that go into taking care of your patient?
Well, thank you, Adil. I think it prepares you to the next case you do, because like for instance, the last case I did of tuberculum cell that goes behind above the diaphragm to the prepontine. I think that lady also had transient DI, but my resident, we just learn how to manage such patient because, you cannot wait forever for the endocrinologist. Even if there is a need for endocrinologists to be there, we try as much as we can to do like the ICU for our own patient, the endocrinology for our own patient. So you learn how to manage those complications. You learn from the previous case, and you expect when you expect the complications, and then you're waiting them at the end of the case. It's not like they're not going to happen. I think even in HICs they'll still happen, but they'll still managed adequately. it's not like you can avoid them. Sometimes you cannot avoid them, but you do know how to manage them. So we just learn how to manage them.
Yeah, I would like to make a quick comment about that because as Claire, I also had a problem doing cases around the world. You know, I over the years got invited to perform and then do some demonstration during courses, live surgery over the world. I'm not going to mention the country, but I had a patient that I always, when I do that, I round on the patients for 1 or 2 days to home, feel that very well. And then like something that you've done. And so the bottom line is that they did not recognize the hyponatremia was an issue to correct quickly. So they actually corrected extremely fast a hyponatremia, and the patient ended up with a lesion in the pons. So that shows how important is perioperative management. It's just not the surgery. You know, that made me really meditate and think about a million times about doing surgery abroad. Those things can happen. It's amazing, like Claire explained very well, like it's just not us, it's a team of people. You cannot take care of patients by yourself. You need the nurses, you need the teams, you need the ICU. And this patient example I gave was also in the ICU. So just ICU, it doesn't matter if they don't have the preparation, the knowledge of things like that. It can be difficult. So the only thing you can do is to educate people around you, Claire, for next stage, and kind of keep teaching and working hard, and paying attention on the perioperative period, as pre-op and post-op are very important as well. So I agree with you. I have a question for Lucas very quickly. Lucas, could you tell us like the mechanism from people from Africa to do fellowships in Brazil? Just if you could briefly mention that, because I think we have some examples in the audience, but what one need to do from Africa to have some fellowship perform in Brazil? You're muted, by the way.
For fellowship or for residency?
Either way, any training.
Yeah, I believe there are more programs of residency, but of course there are for fellowships also. There are some agreements. For example, I have one resident now from Angola, from Luanda, Fabio, and it was an agreement with their government and the university here in Belo Horizonte. So the paper was to their government and not direct with us. But I believe there are something about WFNS also, programs in, for example, in the north of Brazil. Anna is here.
Yeah, maybe MIKAIL can explain how you did the fellowship with Professor Borba. MIKAIL, was you reach out personally, or there was any other mechanism?
Was personally, Professor. Was personal.
Right. Claire?
My government don't have a support to do residence out of Mozambique.
Right. Claire, do you want to say something?
Well, yeah, I think, from that time, I think Lucas and MIKAIL, I think we're all in the same, same age of practicing, and probably some period of training. And that time there were so many training programs. So my own experience is I just wanted to do neurosurgery. There was no way I could do neurosurgery. So I went to the internet, interestingly, and I found the WFNS. And when I went to the website, I saw that WFNS had training programs, and I saw that there is a program in Morocco. So that's how I ended in Morocco. It's not like someone recommended me. It was me digging, finding a program for myself. So the fellowship, same. So Morocco, kept going around, meeting people, meeting Golby, meeting everyone, opening doors, connecting, and, finding the next opportunity. So that was the time. Now I think in Africa, we have so many training programs, but I think it's the time we shift from basic neurosurgery to specialized neurosurgery because, you know, those complex cases exist, those complex spine cases exist, complex vascular cases exist, complex skull-based cases exist. So we're good in terms of trauma, you know, and all other stuff, but we need to now start thinking about, you know, being efficient in more those complex cases. And I think that's the role of maybe building skills lab or fellowships and etc. And collaboration, of course, with HIC.
It sounds to me, based on your presentation, Claire, that you could have your own fellowship there now. You're doing
I
some
think
good
I have
things.
a pretty great number of cases,
Yeah,
but I still struggle. But I think it's coming. Maybe in 2 years and so I can have. So far, people will come maybe for the course, which is good. They get the the skill, but 5 days is not enough. Then you need to go to the theater. And you need to see those cases being done, and that's the role. And I think I grew up so much when I was doing my fellowship rather than when I was doing my residency. So it's you have to get there.
very good.
No, I think it was particularly illustrative, Dr. Karakezi, when you mentioned that you went to a skull-based lab, you saw a case, and then that gave you the confidence to do it the next day or the next.
Yeah.
Really
I've seen it several times and I will see the FTOC, but I said I can never do it. But when I did it and when I saw the patient, when I saw the one piece, when I saw the cosmesis, I said, okay, I'm there. I've done it. I just done it, Yeah.
Yeah, I think it's those short moments that give you the inspiration to then take it on, and then you become the teacher the next time around. So this conversation has got me thinking more about how we can ensure that people get those maybe low number but high quality learning opportunities so that they can then have the confidence to tackle those cases, learn the nuances themselves, and then share that throughout their communities. So I'll pause there, see if anybody else has any questions, Dr. Abdul-Bar, or from the audience. And then if not, we can be respectful of time after another 1 or 2 questions and close it out. So I see a couple of comments just from the audience as well. We have people from Madagascar. We have thanks for multiple presentations. Sayyid Ali, I was asking about the number of MRIs and CT scanners. Obviously, that's very different in different countries. So we heard a little bit about that, and we can point them towards, perhaps via email, the final numbers on those. And then I see other people sending links for other updates. That's great. So anyways, Dr. Abdul-Bar, any final questions? And then I'll just tell everybody about the study that we're hoping to do, and then we can close out. You may still be muted. Yeah.
Sorry, I'm muted. I think this is a great first start. So maybe you can give your idea, and then I think we can wrap it up.
Perfect. Yeah, so just so everybody knows, obviously the neurosurgeons in the audience, we are hoping to formalize this type of this topic about how do we grow skull-based surgery through a publication where we hope to survey neurosurgeons formally and as many LMICs as possible to really get a sense for what their current capacities are, what their biggest challenges are, and how we can hopefully take the next best steps forward. So we'd love all of your inputs in this. If anybody's interested, I'll put my email address in the chat as well so that everybody can see it. It's just my first name, last name at duke.edu. But please do keep an eye out for that survey, fill it out if you can. And I'm open any point to speak via email or Zoom about anything at all related to this topic. Would love to help make sure that we continue growing our skull-based capacities around the world. So with that said, there's my email. Really appreciate everybody joining tonight, especially our speakers, Dr. Prevadello, Dr. Abdul-Bar. It's been terrific. So hopefully we'll talk more in the future.
Have a good day.
Have a
Thank you all.
good day.